over. The day that I saw her and the day that I submitted this case, so I didn't know her real well when I submitted this case, but she had been with our program long enough. She was very kind of withdrawn when she first came in, and she was just starting to become more, I think, comfortable and to talk more. Anyway, the day that I saw her, she said she was having severe cravings, and that she had, even, over the weekend prior, we meet on Wednesdays, she had planned to use, but she didn't. And heroin was what she would have used. And she was just very frustrated with her cravings. She couldn't really pinpoint what was causing the cravings. And she was asking for a higher dose of medication that day. And I think this was her first time using Suboxone. She at least had not been on it in the recent past prior to going into rehab. At the time when when I put this case together, she had had good attendance at her medical group visits and her NA meetings. She had missed an individual behavioral health appointment, but was rescheduled. And she was really starting to open up in group meetings with the counselor. At her request, 2 weeks prior to this visit, I had changed her from films to tablets because she said she could not tolerate the taste of the films, and that at that time that was causing her to think about relapsing. And she was really happy about that and felt much better since she had gotten the tablets. And she lives alone. She has one child who I think is 11, I think. Also pertinent to the social history is that she does have family nearby, and a lot of people in her family have substance use disorder and are not in recovery. She also has a lot of psychiatric comorbidities, depression, anxiety, bipolar, as you can see, in ADHD. And we really struggled with her in the beginning, getting her appointments with psychiatry in our organization and getting her medications refilled that she had been on prior to coming to us. That remains a little bit of an issue. The day I saw her, she was tense, and she was talking about how strong her cravings were. And I don't think I put on here, before I get to my questions, Elizabeth, did I put her medications on here? She's on quite a cocktail of oh no, I didn't put her medicines in, so you can scroll back up. I apologize that I didn't include medicines, and if you guys wanted to know that, I could look. I don't have them memorized, but I mean, she was on about 5 different medications for depression, anxiety, and bipolar disorder. And so when I was talking to her that day, I told her that we did not prescribe more than 16 milligrams, and that it was unlikely that I was going to increase her dose. And I offered to have her have more intensive counseling, which at that time she agreed to, although I think she failed to follow through on that. And she was also using she had just gotten enrolled in the dynamic care, one of the dynamic care studies, and she was using the app. She was just sort of getting used to it. But I wanted to ask about maximum dose, because I knew I had heard on Echo that there were studies ongoing about increasing dose to 24 milligrams. And to be honest, it's interesting to sort of observe oneself as a prescriber in these situations, because one thing that I am not very good with is tears. I tend to get very, I feel really bad when people cry. And also, in her case, she wasn't crying, but she was just so agitated, and she was so worried that she was going to relapse. And that really tends to bother me. I don't always feel like, the the risk of relapse and the risk of overdose is so intimidating to me, I guess, or not intimidating, but ever present, that I feel this probably overwrought sense of responsibility and anxiety about, people not using, and what am I making sure, am I doing everything I can do that they don't use, which really that's kind of my own problem, because it's also a choice on their part. But at any rate, I was when I turned in this case, I was so worried about her cravings, and I thought, what is there ever an indication to increase to a higher dose? What we did when I told her I likely wouldn't be increasing her was we offered her more intensive counseling, because she needed to figure out where the cravings were coming from, and then I also had her, at that time she was scheduled with the psychiatrist to go over her medications, and as I say in my last sentence here, I really, throughout the course of working with this woman, and there have been other issues since I presented this case or wrote up this case, she really, it seems to me that her psychiatric illnesses are a big part of her struggle to remain sober. So that's the, believe it or not, that is the nutshell version, even though that was a heck of a nutshell, kind of long. And I would be happy to try to answer any questions that anybody has. But the basic questions are about cravings and about medication, maximum medication doses.
Great job. Thank you so much, Jennifer, as always. We did get recommendations, but I, would like those individuals to discuss it with the group so everyone can kind of hear those recommendations, and also others can speak up if need be.
Okay. Okay. So this is Dina. Thanks everyone for being here. And so a couple of things. So states are very specific about the amount of Suboxone you can use, right? So when I worked in Connecticut, we could go up to 32. Okay. There are patients whose cravings will not be controlled by 16, even though most states, even though most studies says between 8 and 16, you should be 10. So some people are rapid 2D6 metabolizers. And for her, what I'd actually do, I'd probably do gene testing on her to see if she is a rapid 2D6 metabolizer, because if she is, that can give you some kind of leeway in trying to appeal to Medicaid to get her a higher dose if she needs it. And you can use the diagnosis of depression as well as opioid use disorder to get that test, and Medicaid does cover it. The second thing is, some people, even when you titrate up all the way to 32, still have cravings, because Suboxone is not for everyone, and you might have to offer something else such as methadone. The third thing is, before I even do that, I would try Sublocade, because that definitely hits all the receptors, provides a higher steady state than daily Suboxone, and just maybe take it from there. So maybe do gene testing, since it's a rapid 2D6 metabolizer. Next thing, if she fails your dose of 16, try on Sublocade. If it doesn't work, maybe suggest methadone.
Thank you. Dr. Bray, your audio was a little bit garbled there, but so thank you also for repeating. So genetic testing, and use the diagnosis of depression.
Yeah, MDD, and also says she has concurrent OUD severe, and they will test her for all the different genes, and you can also get tested for that.
Okay.
2D6 rapid metabolizer.
Okay, and then also you said methadone and also Sublocade. Maybe not in that. Yeah. Sublocade first.
So Sublocade first, and then try methadone. But like if she is a rapid 2D6 metabolizer, you could get prior authorization from a Medicaid to get higher doses of Suboxone.
Okay, and so it's rapid GD6. Is that what you're saying?
2D6, yeah.
Okay, 2D6. Okay, and are those? I've never ordered genetic testing. Are they easy to interpret for somebody who doesn't?
Yes, incredibly easy. And what they do, like the patient can call and get the results, and you can just sit with them and read it. It's super, super easy.
Okay, that was.
Because you just read it and they tell you yes or no.
Okay.
Okay, thanks.
Thank you so much. Does anybody else have any comments or questions?
So just a follow-up question on that 2D6 as I was hearing it. I think I heard it correctly.
Yeah.
Isn't buprenorphine metabolized by 3A4?
Yeah, but I thought some of it does go to 2D6. No?
Not really.
Oh, okay. That's what opioids said.
Yeah. Now where it gets confusing, and folks, that we're all learning here, so please correct me if I'm off. I don't care if I'm a pharmacist or the pharmacist here. The active metabolites of buprenorphine can, depending on what study you read, they can be 2D6 inhibitors. Hence, when you see publications out there, that gets confused all the time. Am I right here, folks, or back me up, somebody? It's kind of important. So, all right, whatever he says is good then. All right. I know for sure it's 3A4 because I always think of grapefruit juice.
That's nice to know.
Grapefruit is 2D6 though, bro.
Nope, 3A4. So 3A4, if you ever have to guess, oh gosh, we record these things, right? 3A4 is the most common medication interaction for pharmacogenetics, or PGX. That being said, 2D6 is probably one of the most common variants that actually affect medications. So 2D6 would come into play with things like tramadol. It could either work much better or not at all for a patient, depending on their PGX 2D6. I sound like I'm talking Star Wars now with our 6-year-old variants, basically. But 3A4 is usually the one, or is always the one for buprenorphine. And the variability for pharmacogenetics on that is not too much. To the latter part of that question, for once in the history of mankind, PGX testing results are probably some of the easiest ones for everybody to be looking at. They're usually colorific. They're usually very straightforward. They are the opposite of a PDMP report. They are the opposite of an Excel spreadsheet, for what that's worth.
But Mark, you do have to interpret them like you just said. Are they rapid or slower metabolizers? So it may actually be good or bad, so there's still that interpretation in it, which I think was a good point. Yeah.
It's part one and part two, finding out what they are, they're either, and then applying it. So if you know they're ultra rapid or not at all or whatever, that doesn't give you the end result. It's might mean nothing if it's the wrong one, but whether there'll be more or less of the medication in the body is the ultimate thing there. So
I think it's very nice. We can know you can do genetic testing that apply for approval, authorization. I think thank you. I think this is very important because we struggle to find a way to get it approved if we feel like it's clinically appropriate. And also the genetic testing, usually they give you substrate and give you like all 2D, we're talking about 3A4, 2D6, all different kind of enzymes. So which is a good thing. You give you the whole map. And I think that's also very nice. But I guess my question is, what if the genetic testing says this person has normal metabolism? So then are we gonna increase the dose or not, not to increase the dose? So again, my point is still, from the ASAM conference, I learned basically, and also we are doing like a clinical CTN 100 study, our maximum dose is 32 milligrams. So I still think like, the new findings, at least the clinical evidence is basically for some people, 16 milligram probably is not enough. Now, luckily we have treated 3,255 patients from total. I'm trying to do the publication now, my manuscript now. So basically from 2009 to 2019, and the maximum dose was 16 milligrams. Now, of course, the problem is like we did not retain every patient, right? A lot of patients, we lost a lot of patients. So we don't know whether that was the reason we lost some patients, and our retention was not really that high. It was pretty good. So we still don't know. So I guess it's in this case, it's based on Jennifer's report in that I think two things. One is definitely there's a chance this lady is not doing well with current dose, and we should look for options. But second is like a psychiatric condition. I think her psychiatric condition probably played a big role in her, talking about overall her clinical presentation. I guess my question is, what happened, Jennifer? Did she do better? What's going on? You know what?
Yeah.
So can you tell us? Yeah.
Yeah, so it's an interesting story. So I don't have the dates quite accurate on this, but about we told her we weren't going to increase her dose, and she stopped talking about cravings. And she went a couple of weeks and actually had some stressful situations where she thought about using and didn't, or she came across some heroin in a relative's house and didn't use, so that was good. And then one of her urine confirmations, after about 3 weeks, when she denied using, one of her urine confirmations came back positive for fentanyl, a very small amount of fentanyl. And I told her this, and she denied using. And I reset her days. And at that point in our program, she had, I don't know, over 30 days, or maybe she was pushing 60 even. And this was about a month ago. Yeah, so she might have been over 60, or close to 60. So anyway, she was furious and just so bitter about that she didn't use, and I reset her days, and very angry, threatened to leave the program. And she stayed in the program, but that sort of started a downward spiral for her. And so she did start using after that, and continued to threaten to leave. And most recently, last week, I attended court, and she wanted to switch to another local program that is not based on the quote model. And the judge said, after a conference without the patient or without the participant, but with the drug court treatment team, the judge recommended that she stay in the New River program because of the intensity of it. And he pointed, and she was falling behind a little bit also on meetings, but anyway, so she agreed to stay, and she, it was sort of court mandated, but it was this judge, I love this judge, and he made it as a plan with her, and brought her to see the value of that. And so then I've had one visit with her since then, which was by telehealth, and we're scheduling her back for weekly counseling. And at one point she had stopped her psychiatric medications for a couple of days, and that's when she relapsed, and then she had restarted them. So anyway, so we just really think that the psychiatric overlay here is, or I think that it's one of the big issues. And she has all this support from us, and she has all this support from the court. It's so interesting. That's such an interesting thing to be part of. But so that's what's happening with her. And so it raises this other interesting question about, the wailing and gnashing of teeth, as my mom would call it, about when there's a positive urine confirmation and people deny use. There just is such drama around that. And we just said it's the objective measure that we have, and it just means that you're with us for a little longer. It's not, so anyway, but she's still quite bitter about that.
So what was the fentanyl level? You got the confirmation that GCMS, there was a fentanyl level, right?
There was a level, and it was very low. It would take me a minute to pull up the chart. I think it was something like, I don't know, 13 or something like that.
Okay, our cutoff is 5.
Uh-huh.
But some places 10. So
yeah.
So
you're saying below 5?
No, actually, I had a recent case to share with everybody here. Basically, I had a person with a level of 7. So I was our level cutoff is like a 5. Now I sent a message to our lab people, experts, and they told me definitely it is fentanyl. And basically they reviewed the lab results and also the metabolite. Basically, it is fentanyl. Even if the level is low, their interpretation is basically, yes, it is, fentanyl was there. So
no matter, and would they say that no matter what the level was?
That's the level. Basically, level was low, but it was above the threshold, and
right,
it was
for detection.
detectable. Yeah, it was detectable, and there was a metabolite, very, very low level, but it was there. So basically, patient told me no, and she definitely didn't use. So now I definitely trust our lab people for sure. So
Right.
Yeah.
Right. Yeah, that's interesting to hear. So anyway, this lady is hanging in there, and we'll see. But I appreciated the comments today, and also the feedback that I got when I submitted it on demand from Dr. Zhang and Katie. It was really helpful.
This is Marianne Long. I have a quick question about the fentanyl. Doesn't it stay stored in the fat tissue for a while though? So if you have someone who was using large amounts of fentanyl for a long time, even if it's been some time after their last use, you may still get a low level. I've seen that happen, so I was just curious about that.
Well, for my patient, it was negative before, so it was basically. Gotcha. But of course, it's many. She already got like how many days? 45, 50 days. So it's kind of my patient basically is out of the window already. So I don't know about Jennifer's case.
This was at least 60 days since her last use, and probably closer to 90 actually. Sorry, I don't have all the numbers in front of me, but it's interesting because that came up in another case we had, but the drug was benzo, and I can't remember what benzo it was, but it was a benzo that she had been given when she went into detox program, and it was there for a long time. Then it wasn't there. Then it was there like a month later. But I talked to the lab on that one, and that when it went away and then reappeared quite a while later, they said that it was not likely from the initial ones that were declining so slowly, they said was likely from being stored. But when it disappeared and then reappeared, they said no. But I think it's an important point to keep in mind, it seems.
Great question. Thank you so much, Marianne. Any other comments before we move on to the didactic?
Yeah, I just want to say, Jennifer, I appreciate so much the way that you care for your patients. Your example of you resetting your patients' days, but not dismissing them from your program is an example of trying to meet them where you're at. And just one of the many reasons that probably the judge is recommending she stay with a program like yours, because you're appreciating the structure, but also meeting your patients where they're at.
And I think also as a comment, so many of our patients do have mental health issues, but also the positive and negative effects of placebo or, positive, suggestions on how we treat our patients with, I wish I could give you 24, but I can't. So you're not going to do so well on this versus, most of my patients do really well, and it's the same. And again, I only have experience here in West Virginia. So it'll be interesting to see kind of double blinded trials because it's hard. I think we do pretty well with, 16 to 24, but I'm open to the idea that, probably some people don't. I also know my patients take it variably. They should have steady, their levels should be pretty consistent, but they're all over the place sometimes. And I don't know if that's pharmacokinetics of different times of days, if it's they're not taking it. There's just not a good way that I can feel confident on what's going on. So kind of have a loose use of those levels. But I mean, somebody goes from levels of over 1,000 to under 100, it's suspicious, I think. So
it's interesting.
Yeah, I never know what to think.
Go ahead.
Oh no, I just said I never know what to think when those levels fluctuate.
Yeah, it's tricky. The lab has become my best friend. And I also just have to shout out to the team at New River because I learned so much from Echo, and I learned so much from the team at New River, and I just think that they were doing this for a year with under the COAT model before I joined. And even though I've been doing it for 2 years now, it just feels still so new. And it's to me so helpful to have such a clear structure to practice within and a team to sort through things that are challenging.
I just have a very quick question. Any provider here and has used more than 16 milligram a day, like for some of your patients? I have never. I have one patient.
Yes.
Okay.
Yes, I
How
have to.
often? How often do you do that? I mean,
Very rare cases.
Okay.
Yeah, it has to be really obvious that they absolutely need a higher dose. For example, a short period of time when they're in pain or if they're pregnant.
So pain, I had trouble to get approval for chronic pain because basically I had to, the way I manage it was to write a separate script with like an indication for pain. Then the patient ended up paying like out of pocket. So I felt sorry, but that happened. And for one patient, I still kept that patient on like 20, it's only 20 milligram a day. And so the question is, I couldn't get it approved. How did you get it approved for pain, chronic pain? You just, so.
I only did it for acute pain.
Okay. Yeah, acute pain, like, yeah. I still could not get it approved and they still have to pay. Mark, probably you can give us insight. If we just, because basically the insurance, some pharmacists even refuse to fill the two scripts. One is a separate script for acute pain management and refuse to fill the same day.
So I do that for C-sections and they pay for it and it's not very expensive for a week or so at most. And again, I have to write a note for the pharmacist to allow me to do that. I have had some patients coming out of certain jail systems that have come out on 36 and even higher. I don't know if there's an incentive in certain, private jail systems to increase that. And I've kept people on, but weaned them down. And I know 24 you can do, I think, for 2 months under West Virginia Medicaid. So I have kept those, but then weaned them down generally. So I've I've had long-term, and those people have done okay. I haven't seen it as a problem, so.
So nobody really used the MAT dose for maintenance more than 16. Long-term wise.
Yeah, it's determined by Medicaid.
Yeah, that's right.
It's not even us.
I had a patient in the high-risk pain clinic who I treated for a lengthy time on 24 milligrams for chronic pain and opiate use disorder. And you can put the indications for the medicine on the script. And I gave it all in one script. It was chronic pains. There was no like acute pain, breakthrough pain treatment. It was.
Well, good to know that because I was never, able to do that. Thank you. Yeah.
Hey, just one more question. So how hard do you distinguish between withdrawal symptoms and cravings? And if you were deciding to increase the dose, and because I sort of have this idea that for withdrawal symptoms, it's pretty clear I need to increase the dose. But for cravings, that could be better managed through counseling.
So what came out of the intensifying the counseling sessions? Like as far as insights around the cravings, or did they describe what the cravings were like?
With this patient, I don't have the answer to that. And I think that she actually didn't have good attendance at the individual sessions, and that I didn't get good feedback on that.
That's why we made that our focus for contingency management.
Gotcha.
Do you know if this is how many attempts they've had in the past as far as recovery goes?
I think really this is her first.
Okay.
It's definitely her first with Suboxone, and I don't know if she tried.
You don't know if she's had like significant time before this?
No, I don't think so.
Well, it could be a lot of. Go ahead.
I was just going to say one thing that I see with people who crave episodically is that negative affect can drive craving. And so negative affect can be from withdrawal, but it can be from depression or anxiety or stress, or just the negative events of life can be overwhelming to somebody in recovery and drive craving. And so you have to kind of look at the big picture. Is this somebody who has cravings because they recently stopped using opiates or whatever drug and are having memories and urges to use, or is it driven by negative affect and they're trying to palliate their emotions with a substance?
And also, we're talking about the real withdrawal. You have a lot of physiological symptoms, including sweating, restlessness. We're talking about not able to sleep, increased anxiety. That's what towels do. So basically, we use that kind of as an objective rating scale to assess. I mean, unfortunately, in our group setting, it's almost impossible, especially like virtual visits. There's no way we can just really assess that. It's very hard. So, but a lot of cravings, my understanding is like, a lot of times they say, I really want to use, and interestingly, I learned this from DBS study, our deep brain stimulation study. When we assess patients' cravings, we even ask them like in the DBS study, because we didn't have that kind of privilege to ask detailed questions. We ask each individual, even tobacco, marijuana, what's your cravings for benzo? Like what's your cravings for opioids? What's your cravings for tobacco? So it seems like that our patients, our study subjects were able to give like a score, like a 5 out of 10 and a 6 out of 10 for each individual drug or alcohol. Then they can tell you, like, basically you can see the numbers are kind of different. It's very interesting. So we're talking about the craving. So that's why when I answer your, when I write answer to your case question, so basically I think, I learned this from patients as well. So basically the patients sometimes can tell you what they're craving for. Yeah.
Yeah, it's all very helpful. Thank you all very much.
Yeah, thank you so much. This has been an excellent conversation, but for the interest of time, I think we need to go to the didactic portion of the discussion. I really appreciate it again, Jennifer, and thank you everyone for your comments and questions. Mark, I've made you a co-host. Did you want to share your screen or did you need me to do the slides?
Oh, we got this. No worries. Okay. So in the background here, I've also been cutting away at the slides because I think that opinions are a dime a dozen, but that was a phenomenal case conversation there. So I would donate time to that conversation any day over talking about hallucinogens, stimulants, and cannabinoids. So this kind of a la carte version of things we've talked about in the past, but some of these things come up. Some of them are just a little bit of add-on for us here today, but anybody has any follow-up questions? I know, Adina, we already touched in the chat there. When it comes to any of those buprenorphine things, feel free to reach out. One of the things I did want to point out that was lingering in the background of what everybody was saying was all about those conversations. Like Jeremy, I'll put you on the spot. What you didn't mention there, as far as how the high risk SUD pain things roll, is there's a lot of proactive conversations by the entire team. Sometimes I actually even get to hear them in passing in the hallway or whatever, and it's like people calling pharmacies, and I'm like, oh my gosh. Usually it's my folks calling whoever and getting recordings and all that. So that open communication, the anticipation of yeah, that's probably gonna raise an eyebrow or two. Make a phone call. Yeah, you're probably gonna wait just like everybody else waits. I mean, any one of us as a healthcare professional could say, call yourself, go for it. Probably get there quicker than calling Comcast, but go for it. Try and reach yourself. It's probably physically impossible. Tell that to the Ruby folks all the time. I'm like, yeah, I know you guys got extensions, but come on. All right, so let's hone into these illicit drugs, illegal drugs, substances of abuse. There's a lot of different terminology. Some of them get stigmatic. Let's jump into some of them here, though. We're going to learn. All right, so let me minimize this so I could see my own slides here. But I often utilize this quote because it's from over 100 years ago now. But this is the guy that was in charge of opium over 100 years ago in our country. And he basically said, of all nations in the world, the United States consumes the most habit-forming drugs per capita. There's no period there, but has anything changed? Interesting little part there on that per capita. There are 1 or 2 countries across the globe that will rival us when you go per capita. So the race is actually pretty close sometimes. But usually we're winning. We're losing. All right, so who's... we got a video on for some folks. Who's read some of these here? These works of literature. Lots of heads going, right? Anybody read The Least of Us? That's probably the most recent one there. No heads are going. Oh my goodness. All right. You got homework. I'm on slide what, 3, and you've already got homework. So that's some of you have actually, I physically know that many of you have met Sam. I actually had him on my podcast a couple months ago, basically when the book released. I'm not tied to it in any way, but we've had him here in West Virginia a good number of times. In fact, he included as a focal point of the book some folks from West Virginia. So it's certainly worth our time looking into that as well too. But it was a follow-up to Dreamland, where Dreamland talked about heroin, prescription opioids, the intersection. The least of us is talking about meth and all of its new forms. We'll touch on here in a moment. Some of these other things, I'm sure many of you have seen, read or seen Dope Sick on Hulu now as well. I guess that's a good time to click this one. Here's the cinema, the TV shows, the movies. We could have 15,000 slides of this, but some of them do hit home. Of course, heroin with that E specialized at the end for the southern part of our state. Recovery Boys, Ryan right there in the ball cap in the front. At one moment, he was working up here in Morgantown, actually. Drugs Incorporated, the only way that I know to learn how to make meth in the middle of the woods. They have it documented. They get rid of one of the ingredients. It's like a battery. I mean, it's abundantly clear when you watch the thing. So we have all of our fancy references, but these things are all here too. So drug utilization is in our society everywhere, and sometimes it's hidden and we don't know it. There's lots of songs. I'm not going to play one of the songs today, but here for ones that we're talking about today, here's songs that talk about their utilization. Some are abundantly obvious, Eric Clapton. Others, they try and hide stuff like Miley Cyrus there. Others are like, yeah, we're just going to talk about drugs. It's pretty clear as far as the titles and the lyrics within. But it's out there. And that's the idea, is that it's well beyond healthcare. It's all within our society, of course. Here's a gentleman, Dr. Kevin McCauley. If you haven't, anybody see this before? Anybody have the t-shirt? It's available as a t-shirt. All right. I see like 2 heads going. All right. So for the rest of us, this is a gentleman who spent some time studying addiction in a very interesting setting. And he organized things like there are numerous out there available for periodic tables of, you name it, Star Wars characters, beverages, elements. I mean, gosh forbid we've got periodic table of elements. But this is organized. Left would be your sedatives, right are your stimulants. And then the horizontal rows are all different classifications of substances, or sometimes we say medicines. Then you got the Misfit Island at the bottom. That's just everything else, like sex, Facebook, chocolate, gambling, you name it, Las Vegas 101, right? And whatever else is there. But it poses some unique thing. Anything on here raises dopamine more than anticipated. There's no direct correlation of, well, is cannabidiol compared to ethanol? Is there, they're right next to each other. So is it closer? This thing only goes so far. It's a t-shirt, folks. But it's an interesting way of looking at things. I like to share. Because then we jump into the little pharmacology, and that gets boring really quick, right? So therapeutic index, the difference between what'll kill you and what'll help you. You want more wiggle room. The more wiggle room, the better. In fact, we have that classification of medicines known as narrow therapeutic index medicines, NTIs, ranging from blood thinners to thyroid medicine to whatever, where you don't have any wiggle room to mess up the dose. It's got to be spot on. And your heads are already telling me that you're reading what's on here with lots of wiggle room. That's interesting. It's only one aspect as well. The one that'll sit for interest of time, the one that stands out, of course, towards the bottom, nutmeg. I mean, who doesn't have that in your pantry, right? I mean, we're not Thanksgiving time yet. It'll be here before we know it. Well, it's all about the dosage, baby. I'm paraphrasing one of my favorite characters in the history of mankind, Paracelsus, the father of toxicology. He said, sola dosis facit venenum. Don't worry, that's literally the only Latin I know, sadly. But what he was saying was that the dose makes the poison, not the substance. Too much water, too much chocolate, too much apples, apparently. One keeps the doc away. Apparently, box of crate of 1,000 will keep the doc on you. But it's all about the dosages, how I would say it. On top of that, what makes something so conducive to abuse? In our healthcare terms here. Well, the healthcare terms are on the leftish here, but I want it now. That's fast onset, quick Tmax. I want it all. High concentration max, large peak. So you're thinking like the little charts. I want it be more than anything else. That's the receptor affinity, the magnetism to the receptor. We talk about that with buprenorphine with the mu receptor a lot, like our case earlier. And of course, it has to provoke the release of dopamine, something being better than anticipated to give that euphoria. If you have these four things, you've got a propensity to be something of abuse, an activity or a substance or whatever. So that's nerdifying abuse, if you will. I think no conversation like this is complete without at least mentioning our poison center, 1-800, all twos with a one in the middle. That's how I usually look at it there as well, too. All right, just checking the chat just in case. The usual terminology with this is just say no. Judging by the names and folks on here, I think half of you already know this about me. But so back in 7th grade, I got booted from a spelling bee. And it was because they asked me to spell relief and I spelled Rolaids and no one laughed. I mean, sometimes audiences just suck, even if they're your teachers. No, that is not the point I realized I want to be a pharmacist. It was the point that I realized, yeah, I'm that kind of donkey. But anyway, intelligent one, right? But it brings up a point of maybe we just spelled it wrong. It's just say no, K-N-O-W. And Nancy's going to have some neck pain if we don't calm her down there. So here for this brief conversation today, we got stimulants, hallucinogens, and cannabinoids. Just a quick little touching, a spattering of some of them here. Nicotine, oh my goodness, it's everywhere. I witnessed a conversation a couple days ago where somebody was talking about, oh, well, if you use this, they called it chew, that has a higher nicotine content. Like if they were a CTTS or however many T's they are, some of us have that designation letters, alphabet after our names. But nicotine does a lot. But the big thing is causing arousal. What I attempted to provide here on the right is the chart of showing the different milligrams, the dose. Remember Paracelsus, it's all about the dosage, baby. But how much nicotine is in each of these products. And the big thing today, of course, with e-cigs and vapes, it is the incredibly large nicotine content, which is history repeating itself, just like alcohol and other stuff coming. All right, so since we talked about nicotine, we should talk about methamphetamine. Not only is it a legal prescription medicine as a C2, it's also we're at a little bit of an estuary here. It's kind of hard to find the over-the-counter version of meth these days. But back in my day when I was growing up, this is what my mom utilized on me whenever I had some congestion. And you put the little lip thing that looks like lip balm or lipstick, put it to your nose and inhale it, and you just took some meth. It's left-handed meth, it's levo meth. It's incredibly different than the meth that's abused in our streets and woods every day. Incredibly different. Stereoisomerism gets real when it comes to meth. So the dose would be through the roof. That being said, it's observed to be utilized, misused, abused, whatever the terminology is selected by truck drivers when the old school formulation is found. They actually use the international chemical name as an abuse deterrent effect or strategy. They said, well, if we call it levo methamphetamine, they'll steal it off the shelves, just like they stole Oxytrol because it had oxy in it. Anyways, pharmacy stories, man, they roll deep. The overall point here, though, is about access in the big picture. It is a legal medicine, but usually we're talking about the illegal stuff. Us in healthcare, we flex our muscles incredibly well sometimes, and then there's what happened with meth. So there's lots of different ways to make meth. We're not going to go into the specifics today. I'll leave that for Drugs Inc. for you. It's the Kentucky or Nashville episode. Tennessee, I guess. There's the reductive methods earlier, and we cracked down on that by having the Sudafed laws where you got to give your ID and your firstborn to get a Sudafed pill because you're congested and it's Sunday morning. Oh my goodness. So the states there that have that, of course, we're included, are on there. And the street chemist said, yeah, that's great. So we'll just make the precursor to the original precursor. And now you can, meth is everywhere. And to Sam's book that I talked about earlier, talks about, he phrased it as new meth. It's not really that new. But anyways, he wrote a book and it's bestseller, so we'll give him credit. But the point is, it's our responses are so questionable because it's a game of chess. It's not checkers. The streets have been playing chess and we're hanging out as checkers. So what's next would be one of the follow-up questions. All right, well, for this conversation, what's next? Here's how I look at, and it seems to please some folks, those that like to organize things, if you're a little CDO. Hallucinogens, here's the different groupings that I would put them into for the abundant amount of hallucinogens that are out there. You have your things that would be more natural, has to be good, right? Mandrake root, like you see in Harry Potter, the alkaloids. And then you have your anesthetics, like Special K. We use it in hospitals across the country every day. You have your serotonin, like tryptamines. You have your dopamine, like phenethylamines. Say that one, not even 5 times, say it once. There's nutmeg, right? What's up with him? Good golly. And then, of course, we have our piperazines, which just aren't as cool as the other ones, I guess. But some of these names that you're seeing here, you've seen before, and others you're probably wondering about. If you're wondering a lot, let us know. Could certainly go deeper someday, but this is the first hit here for this conversation anyway. One or two big things when it comes to the hallucinogens, though. When something's illegal, we automatically, all of us, present self included, kind of sink our teeth into things, saying, "Oh man." Well, let's just think about things a little bit differently. So this is me in art. I can't draw anything, but I can use PowerPoint. When you're thinking about atypical antipsychotics, first generation, they were antagonists to dopamine. Second generation, antagonists to dopamine and selective to serotonin, but big picture antagonists. Hallucinogens are typically just agonists in the same exact way, yet exactly opposite. So they work exactly opposite of our second generation atypical antipsychotic medications, which is a big thing because it's exactly opposite. But as far as mechanism goes, we're in the same ballpark here. So just an interesting way of looking at that. Second interesting point when it comes to hallucinogens, I think we're good on time, is I'll pose it as a question. Are folks actually looking to enter into serotonin syndrome when using a hallucinogen? Well, the answer is sometimes yes, almost always kind of yes, but certainly not knowingly. I mean, you could pull a bunch of peeps on the street and they're probably not going to even know what serotonin syndrome is, but they might be seeking it. The reason I mention that is because if we have our teeth wrapped around serotonin syndrome, you can then remember what some of the major effects are for hallucinogens, especially based on higher doses. All right, I got rid of my filler slides here, so we're jumping right into cannabis and words matter here. This is, I'm probably gonna need 5 different versions of this before I figure it out. So there's an extreme confusion out there with the utilization of terminology about everything about cannabis, cannabinoids, and everything you see on this screen. So here's an attempt at whittling it down. Cannabis is, if you look towards the left here, genus, species, pretend we're in like 7th grade again, maybe 4th grade, of plants and botany. This is where I'm a farmer with PH, right? Okay. So it's always cannabis. And I want to emphasize that it's always cannabis when you're talking about a substantial incremental dose of anything of a cannabinoid. The species can be different. And in today's world, we have so many hybrids, just like when you go to the farmer's market, those of you at the HSC Wednesday, you see different hybrids of tomatoes, depending on where you're at. There's lots of hybrids out there. So to talk about cannabis sativa, as I have highlighted here in rectangles, indica and ruderalis, is kind of ancient. There's a lot of hybrids. But in talking about the terminology, though, when somebody refers to, say, marijuana, it can be any of these because that's just weed, marijuana. It's not saying what's actually in the product as far as a cannabinoid, because THC could be in any of these. When talking about CBD or even hemp, you're typically actually talking about cannabis sativa. But you could be talking about cannabis sativa if you say marijuana or weed. See how it's incredibly and frustratingly confusing? And this is what I want to talk to the media about, not healthcare folks. We got enough on our hands. Of like when there was a headline a couple months ago, actually probably near a year ago now, where the headline said that weed would cure COVID. Well, what was that talking about? Let me just go to the next slide here. It was talking about this puppy right here, CBGA, cannabidiolic acid. It's like the mothership of all the cannabinoids in the plant. This is not in our bodies. You are programmed as a healthcare professional to think I'm talking about metabolites here, and I'm not. This is what happens in the plant. You start with CBGA, it's in all the plants, and the plant changes it to eventually CBD or THC or even CBG. So this is the origin of THC and CBD. But to get that in the plant readily right now is almost impossible because the plant's changing it along the way. And that's what was studied in that COVID realm. You could check out, just Dr. Google, treat you well with that one. But the bottom line is it all starts with CBGA, and this is trying to wrap our heads around all the different cannabinoids in like 30 seconds, right? CB1 receptors compared to CB2. The physical number 1 is skinnier than me. So CB1 receptors are central to the body, usually CNS. The number 2 is wider like me. So CB2 receptors will go out to the periphery, like wider in looking at the number itself. That's the bottom line there. So now when looking at our 2 heavy hitters, THC and CBD, how do they work? The main part within the endocannabinoid system is CB1 and CB2. As you hopefully can see here, you even made it colorful for us. THC is a partial agonist. Oh, let's not talk about partial agonism. I'm already banging that drum with buprenorphine, right? But that's for CB1 and CB2, same thing. CBD is different. It's an antagonist at CB1, and it's a, tell me if you've even heard this word before, a negative allosteric modulator. Anybody hear that before? I know, on my own island. What does that mean? It means that it binds like an agonist, but it produces the opposite effect. Well, isn't that an antagonist? No, sir. It means it binds, like say, and it would, like if it was binding and the agonist created constipation, this will bind just like an agonist, but it'll give you diarrhea. Go figure. Those examples have nothing to do with CBD, by the way. But that's just how the 2 things are working in the background. One of the last things I do want to go over here is just the different products. This is incredibly important, and I bang this into pharmacists' heads, because if I walk into one more pharmacy where they have products on their shelves and they have no idea what they have on their shelves, I might lose it. But FBI, okay? The FBI show up for the different products for CBD. Full, broad, isolate. That's the FBI. So full means it could have anything in it as far as cannabinoids, meaning it can have THC in it. That can mean someone's job. Okay. That can mean a lot of other things too. So if someone's using a full spectrum CBD product and they spike a urine for THC, there's your culprit. Broad spectrum is saying it's going to have all the cannabinoids, but supposedly not THC. Whereas CBD isolate, I'm not going to insult your intelligence, is obviously intended to be just CBD. These 3 letters are incredibly important, because when you look on the shelves out there, you already have homework. So here's a field trip. Just go to any fancy neon sign or pharmacy and go look at their products. And I guarantee you that you're going to see some full spectrum ones. And should they be there? I don't, maybe everybody's got their opinions.
Can I interrupt you and ask a question?
Sure,
That was
sure.
interesting. So full, broad, and isolate, are those, who, is that an FDA requirement that they put that on the label? Why do they put that on? Who requires them to?
There's very little, if any, regulation.
Yeah.
I would like to say there's none, but like at some point there's some, as far as the regulation for what has to be on there. But
yeah.
Consumerism, capitalism is still driving this. So there's more and more testing done on these products. If you look at the studies for even 6 years ago, there was a bunch of them then, but 6-7 years ago, what the label said and what was in there was significantly different than if you look at products today. Yeah. And obviously with absolutely no FDA oversight, that's capitalism in effect.
So interesting. But so they will be labeled with this often, yes, or always?
It's there.
Okay, interesting.
It might be very fine print. It's usually rather large print, quite frankly, but so it's just something to look for because it's like the label, the writings on the wall, and
Yeah, gotcha. That's helpful. Thank you.
Nope, no problem. Everybody always loves that one. That's why, and when you're saying FBI too, it catches ears. So,
But
here's our
also, I'm so sorry to interrupt, Mark. I think
Nope.
I also hear you confirming. So even though it says broad, even if it's labeled broad, could still have other stuff in there. Even if it's labeled isolate, could still have other stuff in there.
there is no regulation monitoring something to say that what is in there is in there.
Yeah.
The capitalism that I refer to is that eventually the cream will rise to the top with companies doing more third-party testing. I mean, if you test your own stuff, come on. And how often? I mean, now, truth be told here, let's be fair. For FDA products, what's on my, I don't run a pharmacy now, but back in the day when I ran a pharmacy, was every pill tested on my pharmacy shelf? Absolutely not, obviously not. But there was certainly more quality testing. That being said, guess what that does? Costs incredibly much, right? So these products that I have on this screen are incredibly more expensive. The Marinol, Dronabinol, maybe not quite as much compared to these other guys that are thousands of dollars compared to what the fancy neon signs in town have. So there's that balance. And it's interesting where we'll be in about 10, 15 years to see where we get to. All right. One last thing. Definitely want to have everybody on here for like when we were talking about the SIP 450 things with Bupe for CBD and THC. There's interactions. These are your heavy hitters when it comes to SIP 450. There's interactions. That's why some states, our neighbors to the north in Pennsylvania, where I'm originally from, Scranton, the Electric City, they mandate by law to have a pharmacist within a dispensary. That doesn't mean that, the grass is greener or something. I mean, it just means somebody's gonna be going over the interactions. Hopefully, there's no requirement that they have to. It's just they have to be in the building. But the point being is that if we're interested in that FBI thing I brought up, then this should kind of catch some eyes as well too. So lots of interactions. All right, so that's kind of that wrap up there. Big picture, what we were just talking about and hundreds of other substances as well account for 6 figures now. So U.S. annual deaths, 100,000, well over that now. So every 6 minutes, alcohol related deaths are about the same. Tobacco, still so much more. So, I did keep this one here. So this is no, Dr. Volkow was chatting with her at they call it the RX Summit, but the RX and Illicit Drug Summit this past April. And since I had my podcast there, I got identified as media and clinical, I guess. So I got to chat with her not one-on-one, but it was like 4-on-1, but which was great. And one of her big things, I'm not going to read the slide for once, but it's basically saying it's access to the substances that matter in addition to the dose and what it is and how it works. The more access, hence, you can see on that back slide of tobacco, but still being, even though there was how many billions of dollars decades ago, and it's still. So where are we heading? No presentation would be complete without at least some references for folks of where to find help. You never know. And it's us in healthcare as well, too, obviously. And if you want more information, get ready to read. There's thousands of pages out there. Feel free to shoot a question anytime as well, whether it's LinkedIn, email, whatever. So that's that. I appreciate the questions along the way. If kind of nailed it on time, I guess. If anybody has any now, I'll gladly chit chat. So you check the chat actually.
Awesome. Thank you so much, Mark. That was excellent. And yeah, we're just at that time, but we do have you next time as well. So if anybody thinks of questions before now, till that time, Mark will be with us. He'll be doing his presentation on the 22nd on urine drug screening and drug testing. So we can continue this conversation that day as well. Does anybody have any quick questions though before we go, or you want to discuss that next time? Got thumbs up from Katie. I think we're good. Derek, love the shirt, Derek. Awesome. Well, thank you so much, everyone, for joining us today, and we will see you next time. Have a great week.
Peace.